Good afternoon, everyone. Thank you for joining. We are going to give perhaps 1 or 2 more minutes for other people to arrive, and then we're going to start. Oh, I think my mic was off the whole time. Well, are you fine with clicking this button, this thing? A bit unhandy. Or I can't do it while I'm doing, yeah. Or you can just do the admit all thing. So if I undo the mute mic thing, then we can start. Okay. Yeah. Yeah. Great. Hi, everyone. Good afternoon. Thank you for joining. We have good turn up already, so I suggest we start. This is the 4th webinar that we are doing from the Wimmy office, and the second time we have an in-person event, at least from our perspective. So I'm joined by Dr. Jessica Hamuy Blanco from Dis-Chem, and I'm very excited to talk about all things science and innovation and how the academic space and the corporate space, how they work together and where they meet and how that works. Welcome.
Thanks. Thank you, Wim. Thanks very much for having me.
Thank you for coming all the way.
Yeah, thanks.
It was a very tight fit, but we made it.
We made it.
Let's start by maybe just introducing yourself. I know a little bit more than the audience, but not that much more. So.
Perfect. Thank you. So yes, I mean, I'm Jess. I'm like more formally known as Dr. Jess at Dis-Chem. So I do have a medical background. I qualified in 2015 from WITS, and I then went into doing my sort of compulsory clinical years. So I spent 2 years doing internship at Baragwanath Hospital, and then I did my community service at Helen Joseph. I was placed in the anesthetics department for that year. And then subsequent to that, I spent a little bit more time doing anesthetics in the public sector as a medical officer. And then I moved into private, still doing anesthetics, but at that stage then I worked for myself for about 18 months. So it gave me that exposure to kind of both the public sector and private, and was very interesting to experience both. And then I reached a point where I had to decide whether the specialization in anesthetics was something I wanted to pursue, potentially in another area of medicine or something else altogether. So I made the decision to just try something a little bit different, and I went back to university, started doing a master's in sports medicine. So that was a 2-year course that I did, started while I was working for myself. And then about halfway through that course, I actually then changed career paths quite drastically and started working at a company by the name of Health Window, which is one of the subsidiaries of Dis-Chem. So I've been in the group since that point, which was about early 2020, and finished that master's degree. And then and at the end of 2023, I moved over into Dis-Chem, into this product and clinical risk space that I'm in now. So it has been quite a varied sort of journey. I do get asked quite often, how would one make the transition from clinical medicine to corporate or to the business world? And I guess there's no straight answer. I mean, I can't really say there's, certain steps you need to take. I think it was just a function of me being a bit open to exploring different things, and when opportunities presented themselves to see what they could bring.
Mm-hmm. Yeah. So you worked as a practicing physician for a while, and so I have 2 questions. While you were studying medicine, was there any sign already then that maybe clinical medicine wasn't going to be your entire career? And my second related question is, clearly you still decided to become a clinician. How or where did you think actually maybe I want to do something else than see patients?
Yeah, I think, and they are quite related questions. I mean, the signs that sort of came up quite early on, and I guess during that time that I was doing internship, it's just this exposure to a number of different problems in the system. And it's really this feeling of, there's really nothing I can do about this. So yes, you can help the person in front of you to the best of your ability, and you try to do that. But there were just so many constraints and so many things that we would feel the effect of, but it felt like we were just, at the mercy of that. There was nothing that I could really do about it. So you end up finding yourself complaining a lot about it, or you find yourself a bit, disengaged or demotivated because of those things. But it just felt like there must be a way to contribute a little bit differently to this healthcare industry or this healthcare system that I'm obviously still so passionate about, but it just felt like the way in which I was playing into it at that point didn't really do justice to what I wanted to do. And then I think the outcome of that was really this, I guess, inherent searching for other things that could allow me to do that. And when those opportunities came up, and I thought to myself, well, this could be a way that I can start to influence healthcare from a slightly different angle and on a bigger scale, that it should be something I should pursue. So I think there were always, sort of suggestions or murmurings of this, I guess like an unsettled nature in working in clinical practice. And it's not to say that the job of treating patients one-on-one isn't something I enjoyed, but I just think it was too narrow and too constrained given what we kind of currently experience in the industry.
Thank you. Just a point of logistics. Can you unmute your mic?
Oh, sorry.
So I muted it because otherwise the camera keeps switching over.
Oh, okay.
Oh, so we're good now. Okay. Thank you.
Cool. So you went from clinical medicine to corporate, but now you are doing a PhD. So there's clearly still an attraction to the academic space. Can you say a little bit more about that?
Sure.
How that came about?
Sure. I think that there's just this, and I guess attraction is the right word, to the methodology and this kind of rigorous way of answering questions and of unpacking more knowledge. So I didn't really intend to do a PhD. It was something kind of always in the back of my mind and an option that I could pursue, but I always thought, I'd do it kind of far in the future. And then when I was at Health Window and I started to get exposure to different sides of the industry and also just this really unbelievable wealth of data that exists. And, as a consumer, you kind of go into a retail store, you go into a pharmacy and you shop, and it never landed in my mind just how much information you get from that kind of action. So I go into the store, I pick my products, I swipe my card, I pay my money, and there's all of this stuff being collected from this, millions and millions of actions being taken every day. So this was my first exposure to considering what insights and what kind of behavioral understanding we can get from that. And once I saw what was kind of in front of me and the kind of value that we could unlock, it just felt like a no-brainer. I thought, like, this is a research topic that's kind of begging to be written up. And it just felt like an opportunity that I couldn't pass by. So I made the call to kind of do it. And I think it also just really was so closely related to the work that I was doing that it made so much sense to have a deeper understanding of it. And again, if, through this methodology, I could build something that was really credible, validated, then it can amplify the value even more. So I just think it was right place, right time. And again, just, being willing to kind of take that on.
Mm-hmm. So for the audience, can you explain what your PhD is about?
Sure.
And how you were able to tap into those resources that you were working with day to day that gave rise to the topic?
Sure. So broadly, I mean, the topic is really focused on the relationship between medication adherence and mortality risk. So the company that I was at, Health Window, I mean, what they do is manage adherence to chronic medication for various clients, Dis-Chem being one of them. And it's relatively simple kind of sounding interventions. There's a call center and there's kind of digital platforms that, you know, prompt this or order of chronic medication. But it's had really significant effects in the Dis-Chem world in particular in terms of increasing the overall adherence rate within the chronic population. So the reason why that becomes so significant is that if you think about someone who's on chronic medication for a condition like high cholesterol or high blood pressure, they need to take that medication every day and exactly as it's prescribed. And every time that they miss a dose, you know, then it increases their risk of having a complication down the line or even having an acute event sometimes. So what we did was to monitor the number of months out of the year that a chronic patient had actually had a dispense of their medication. So obviously if someone is prescribed something for 12 months and they only have bought it 3 out of the 12 months, they're obviously not taking it, and then this becomes quite a big issue for downstream risk. So what I was really trying to understand, because the relationship between adherence and risk, it seems obvious, but there wasn't actually a lot being done about it. So this investment that Dis-Chem had made in an adherence management service, as an example, is not something that was widely done across the industry. And the value at that point was really around, you know, driving more purchases of medication, and that was the rationale for doing it. But there's so much more that comes out of increasing that adherence rate. And what I wanted to do was understand whether we could prove that there is a strong relationship between adherence and mortality risk. And if we were to understand that, you know, what are the applications of that? So the PhD project itself consists of 3 articles. One is a literature review, really kind of looking at global publications on the topic, and is there anything that suggests already, like, what do we know about that relationship today? And then we also created a score using adherence as one of the components, and then we've also used the link that somebody's been on a particular treatment, and we've kind of weighted different disease areas within that score as well. And part of the project is to actually show in a statistical analysis the relationship between that score and mortality risk. So again, very fortunate to have had the opportunity to get access to data from Home Affairs that we overlaid onto the pharmacy data, and we could kind of look at that relationship. So that's it's really around validating that score and then proving it through the statistical project too.
And I don't know if you can say ballpark how many people are actually whose data is captured in your data set.
Yeah, absolutely. And this is really one of the reasons why I just thought I can't pass this opportunity up. So, I mean, the data set consists of roughly about 9 million people. And I think the period that we're working over was about 5 or 6 years. And obviously some time was more complete data than others, but I mean, it's a significant amount to look at.
Okay, impressive.
Thank you.
Okay, so obviously or clearly Dis-Chem is an environment where doing a PhD is compatible, or your job is compatible with doing a PhD. I think that's very encouraging, because that's not true for every single environment that one might find him or herself in. What I would like to understand more is the way that the corporate world works in terms of how do you make decisions, how do you learn from experience and then adapt. In my mind, it's quite different from how academics learn. Academics, sort of thoroughbred academics, learn through the scientific method, which is hypothesis-driven and experiment-driven. Very formal, very structured in a controlled environment. In the real world, that's not possible. Can you say something about this tension between how one would want to do it as a researcher versus how you actually now have to do it because you're not working in a lab, but you're working in the real world?
Yeah, I think it's a great question. And I think, I mean, what I would say is that when I first sort of entered this corporate environment, that tension didn't really exist. And there was kind of certain ways of making decisions, and I'll talk to those now. But I think I've certainly felt that tension, and I think it's a good tension, because I think there's things that we can learn from the academic world that maybe we can't apply in exactly the same way, but there's a lot of value to the way of thinking about them. So I guess what I've sort of experienced in corporate is actually almost like an intuitive way of trying to do certain research, kind of methodologies, but not necessarily knowing why or doing them well. So an example is, when we kind of have a new solution or a new service or a new thing we want to test, everyone has the idea, okay, well, let's do a pilot, and we kind of want to do it on a small scale. And once we get the results, we can then sort of scale it up. And I think what sometimes is lacking is this idea of, okay, how are we going to actually test this? And like this hypothesis sort of theory is not really thought about in the same way. So, you don't really have the luxury of trying to test, 3 or 4 different things in the same pilot and trying to get an answer. But, that kind of thing sometimes, it does happen. And the measurements, or how are we going to actually prove the outcome, and what do we consider to be significant versus not, is important. So I think in the real world, and you're right, there's so much ambiguity, there's so much variation, which is just a function of reality. We can't change that. But the way in which we still think about, in that context, applying certain aspects of the scientific method, I think is important. Another example is how, we get kind of really inundated with people with new ideas. They've got products and services you want to pitch and want to sell. And often the story around it, or the way that it's presented, and the way that kind of gets linked to the commercial opportunity is where all the attention goes, versus, how did you get to the numbers that you're showing me? And I think this kind of natural inclination to just interrogate the methodology and like, how credible is that, versus just accepting it at face value if the story matches what I wanted to hear. So I think it's made me more aware of biases that I might have, and also seeing where that potentially comes up in other people too. And I think the awareness in a team of biases that each individual might have and that the team might have, I think is really, really valuable, just so that we don't end up, kind of reaching a conclusion or trusting something that maybe didn't warrant it. So I think the tension that you describe is something that I hope that I've brought to the space that I'm working in, and something that we can apply on a bit of a broader scale, because I think the natural way of making decisions in the corporate space is sometimes too overweight towards what we want to hear and where the commercial opportunity sits, or what it looks like, versus, is this credible? Is it replicable? Is it significant enough? And I think that those are questions that are very worth asking, and even in that space.
So in academia, when you ask a research question, you collect data, you analyze the data, and almost never is there no statistician in the room at some point.
Yes.
And they analyze the data with respect to, and they often, the key focus is on what's the residual uncertainty. We have a result, but how uncertain or how precise is this result? How compatible is it with the hypothesis or other hypotheses? Whereas in corporate, you have a result and end of it, and then you can debate whether how much value you want to attach to that.
Exactly. And often the debate is a little bit more robust if the result isn't really what you wanted it to be. If the result kind of fits what you were hoping to see, the debate's a little bit less. Yeah. Okay.
So you're bringing academic thinking into the organization, or you're strengthening that way of thinking within Dis-Chem. Is there also a movement in the other direction where you bring real world experience? I apologize for the researchers and the academics in the audience. When I say real world, I don't mean that university spaces are not the real world, but I think we know what we mean. So do you also bring that non-academic pragmatism into your research, and do you have conversations with your supervisors that they want to do something that you say, well, actually that's not really relevant, or that's not how this would be applied once the paper is published?
I think so. I think so. I think the exposure that I've had in the real world, as you put it, is it's made me so much more conscious of like, why am I asking this question? And once we've answered it, so what do we then do with that? And does it have, you know, real world value that it's going to add? So I think that's definitely influenced, I guess, the topic itself and the way that the project has been shaped. I mean, I mentioned previously just this access to these enormous data sets. I just think it's really a fortunate position to be in, and it's not always something you would necessarily get from the academic space. It's sometimes a little bit harder to come by the data that you would be looking for. So in those respects, definitely. And I think what I've sort of actually thought to myself a number of times through this process of conducting this research project is that we've kind of put it into this box of, you know, it's a PhD in pharmacology, and we had to put it somewhere, and I needed a supervisor that was linked to a specific department. But in actual fact, I mean, it's spanning a couple of different things, and I probably could have just as easily, you know, argued for this to be a PhD in data science, for example, because it does touch both of those worlds. So imagine potentially even broader than that. But the academic world is generally kind of, you know, in these sort of fields, and it's defined in that way, but the real world doesn't necessarily work like that. So I think it's definitely resulted in a topic that is a lot broader and I guess a lot more fitted to the way that the real world actually works than what I would have landed on if I'd stayed in the academic space.
Okay. Your colleagues at Dis-Chem, are they also involved? Do you brief them? Like, how is that dissemination happening? Is it happening at all, or is there an embargo because you can't share until things are published? Or
no, I mean, so the opportunity to share that information does exist, and it's been something that we've tried to include in our thinking. I think it's really just, you know, kind of open our eyes to what sits a little bit beyond the initial reason why we did something, for example. So like I said, the investment around adherence management was centered around driving more dispensers, and now it's kind of just broadened that landscape a little bit and made us think a bit differently. And I think the business as a whole has potentially started thinking about this concept of risk a little bit differently. And I mean, the fact that we've launched, you know, Dis-Chem Life earlier this year is really testament to that we're thinking about the role that we can play in an industry like long-term insurance because of this role we've got in the industry around healthcare provision. Can we manage risk? Can we identify risk? Which it's a very different set of questions that we're asking now compared to, you know, sort of 3 or 4 years ago. So I think that way of thinking has kind of filtered down, and it's very encouraging to see. And I think there's various reasons for that. I mean, it's obviously not, you know, just myself that's taking credit for that. I think there's a lot that's sort of happening, but it's opened our eyes to just how much, I guess, the various industries are, you know, sort of ready for disruption, and the role that we can play in that.
So what you just said, I think, is a huge difference between how a full-time academic would digest and process the results versus somebody who works in a commercial environment. As a full-time academic, you would present your results at conferences, and you would publish in peer-reviewed journals, and in the discussion section you would say something like, this result has implications for life insurance. And that's more or less where it would end.
Yes.
But no one who actually works in the life insurance space, well, no one, it's possible that they read it, not likely, but possible.
Yeah.
And even if they do read it, they weren't part of the research, so the chance that something tangible happens is not so big. Whereas now you are in the space where the research, if there's this synergy, there's this confluence of it's ethical, it's good for the patient, and it's commercially viable, then those three things, I guess, is the trigger to say, let's do something with it, let's build a new product or improve our product line. Is that the way I should see it?
Yeah, absolutely. And I think this position to kind of be, you know, bridging those two worlds is really, really exciting, because you're right. I mean, you can, and the intention is obviously to publish in a peer-reviewed journal, but it gives it that level of credibility and that kind of reliability. But, you know, it's never that it's sort of directed at the right target audience, if we can put it that way. It's kind of the luck of the draw, and you've sort of done your work, and that's that. But I think here it's the opportunity to hopefully affect more change off the back of it, but also being able to see that and experience it is really, really satisfying. But it's almost in some ways, and not necessarily in this example, but things that we also seeing playing out in our space, is that sometimes it's almost led by the commercial opportunity and what in the corporate space would traditionally happen, and then potentially backed up by research, and then it kind of gives it that, that case and gives it that credibility. So it's sometimes the order's a little bit interesting, but it's definitely so much more practical, and it does feel like there's so much fulfillment that comes out of it because of the real world application that I can see.
Besides studying the link between adherence to medication and mortality risk, are there other research avenues that Dis-Chem is actively engaging in and planning to make headway in over the next few years?
Yeah, and I think it's something that, well, I'm hoping it's something that we'll start to see in a lot more places. Maybe not to the same extent, but maybe we will. But I think some of the things that are sort of top of mind and things that we're thinking about going forward with is in the healthcare space. And here we are again talking about an industry, like I mentioned previously, that's got a lot of constraints and a lot of inefficiencies and a lot of things that we think need improving. And then it becomes a question of how do we improve this, and how are we sure that any new kind of proposed solution is actually better. And then again, it's got to come down to, in my mind, this idea of testing a hypothesis and actually showing that something, an alternative method or something new is actually better than the way we were doing things. So if I'm thinking about the way that primary care is delivered in our environment as an example, I think there's a lot of things that we can potentially tweak or try a bit differently, but it would have to be backed up by an improvement in clinical outcomes or an improvement in cost efficiencies. And I think the way that we demonstrate that is going to be important. And the other element that I'm really interested in unpacking a bit more is interventions around mental health. And I mean, it's an interesting place to look at because it's getting a lot of attention. There's a lot more that's being spoken about, which is all very good. But the interventions that are available, whether it's traditional kind of therapy or things that people are trying to do on a bit of a broader scale, like what is the actual impact of that, both in terms of cost and clinical outcomes? I think it's important that we are able to evaluate these sort of things in a way that puts us in a position to really draw solid conclusions from them. And it's in my mind like those are the sort of things that we should make decisions off the back of, as opposed to things we think might be right, but we don't really have a way of proving them.
Okay. You triggered a question about the South African healthcare ecosystem. My question is around the future. So we are, I think, in between two systems. We're still working in the system that's been around for a long time, but we also know, or at least most of us expect, that at some point there's going to be this fairly dramatic change in system. We don't know when exactly. We don't know what it will look like. We don't know what the rules will be. We just know it's going to be a complete change. How, as a researcher, but also in that commercial space, how do you navigate that uncertainty? How do you both play the game by the current rules and prepare for future changes in the rules? How do you do both at the same time?
I mean, it's a great question, and it's a very interesting space to be in. So I think we have to, I guess, first of all, accept that there is an existing set of rules. So as of today, there's certain things we do have to do, and we understand that, and then it's about understanding how best we can create value within that. But I think you're 100% right that if you look at the state of healthcare in South Africa now, there has to be a change, right? It's unsustainable at the moment in many regards. So it's also about understanding that if this change is coming, how best can I be prepared for it? And I think, at least in my view, one of the best ways to be prepared for it is to try and influence it. So I think the industry is really ripe for innovation and for people to kind of put their hands up and say, well, this is a better way of doing XYZ, or this is a different way to think about funding or to think about care delivery or whatever it is, but then to be in a position to influence what that change ultimately looks like. So I think at Dis-Chem, again, because of the footprint we've got across the country, the scale we've got, the number of customers that we've got going through our stores, like we are in a really good position to influence some of that change, which is definitely part of the intention to say, you know, if we are able to leverage all the different things in our environment and drive innovation in this industry, as long as that is to the good of the patient, and I guess there's various stakeholders in our world that we need to create value for. But if we believe that it's driving the right kind of behavior and the right kind of outcomes, then, you know, to again package all of this in such a way to say, well, if this works in this environment, we think it can work on a broader scale, and it is a potential way that this change can manifest that should be beneficial. So I think it's really about being able to, I guess, drive part of that change, or at least influence it in some way. Interesting.
When we talk about innovation and trying new things, so in a classic setting, in a formal research setting, you can set up a randomized controlled trial, and you can say, either we're going to randomize patients, or we're going to randomize clinics or even districts, and arm A will have this and arm B will have something else. Can you do that as well in Dis-Chem? Can you say 200 clinics, in 200 clinics this will be how we do things, and then these other 200 clinics the nurses will offer something else, or will treat patients differently, or there's going to be a different SOP or protocol? Is that possible or not really? Like, can you experiment given that you have one brand and one routine way of providing care?
Yeah, I mean, it does definitely come with challenges. So because we ultimately are delivering a service, someone is paying for that service, there's SLAs we've got to deliver on, there's expectations in the customer base. It does become difficult. So for us to create a true sort of experimental design is very difficult. And it does mean that we potentially have to think again about novel ways that we try and test things. And potentially it becomes less dramatic things that we test, so that the differences between what we're doing are not so vast, and we're still ultimately able to deliver on the overall service that we need to, but we can test pieces within that. But I think what's always important in all of this is that level of transparency to that paying customer, to say, you know, if we are doing anything different, that we upfront about that, and, you know, that everyone agrees to what it is that's happening. And obviously the idea would never be to do something that is putting anyone in a worse position, but those are the sort of things we'd have to be very, very conscious of. So that sort of experimental context, it doesn't really fit very neatly into a commercial environment. But I think because of the need in the industry and the fact that there's so much inefficiency existing today, that there's, I think, very simple things that we could do that would, you know, the likelihood of that driving better efficiency or better, you know, cost implications, it's just very high. So I think we can feel relatively confident in some instances that if we're going to try something different, it's going to be better. And then it's about proving that it's better, versus taking really drastic action and having, you know, two vastly different methods of delivering care where one might be much worse, or, you know, so I think it's about being really considered in terms of how we actually apply it in our environment.
That's very interesting. So again, with my academic hat on, I would naively think that a formally designed randomized controlled trial has a better chance of creating innovative results, because you can make the difference between arm A and arm B bigger. Therefore, you can make bigger leaps and learn faster. But what's also true, and what I think you help me understand, is that this trial, this research trial, will probably have a fairly small sample size, or it will take long to build up a big enough cohort.
Yes.
So maybe I need 2 years to learn whether A is better than B.
Exactly.
Whereas if you're serving hundreds of thousands of people every month, then maybe you need a week to learn it.
Exactly.
So the learning is smaller in jump, but the time it takes to learn that is also much smaller, and therefore you can make a lot of little jumps.
Exactly.
Within the space of 2 years.
Agreed. So it's definitely not a reason in my mind to not try and do that. I think the constraints are a little bit different, and we've got to do whatever is appropriate for our context. But it's definitely possible, and I think the environment actually does in a lot of ways lend itself to that. So I definitely agree.
Can we talk about AI and other sort of modern forms of technology in healthcare? The technology in healthcare has been true for as long as healthcare exists, I think. So the moment doctors started treating patients, they used technology. Not always digital, but there was always tools and methods to advance medicine. Over the last, I think maybe 100 years, there's been a massive acceleration in the invention of new technology and the adoption of new technology. But that acceleration has been taken to another level in the last few years, where in addition to the tangible things like CT scans or MRIs, there's now virtual and digital tools that live completely in the cloud. What is your thinking around this in terms of speed, safety? Is this a thing we must all jump on? Is it something we need? Are we moving too fast or are we moving too slow? And where do you see it going?
Yeah, it's a huge topic. I mean, and I guess there's a couple of points that I'd want to touch on there. I mean, I think personally, I'm a big fan of the use of technology, provided that we can ensure that it's safe and that it actually does, give some sort of improvement. But I think there's a lot of opportunity for that, and definitely something that we're kind of looking to bring into our space as well. But I think the one thing is that, we have to, in my view, still treat technological interventions or advances in a similar way to how we look at other things in the healthcare space, for example. So, we talk about this idea of evidence-based medicine. So you would only use treatment A over treatment B if treatment A had, stronger evidence or it conferred a better outcome. So the same thing has to apply in the technological space, in my view. We've still got to have that understanding that there's evidence around this to back up why I'm choosing to use this and not the traditional method. I think some of the challenges, and you mentioned like this really rapid acceleration, doesn't always give the opportunity for things to be validated or things to be, investigated in the right way. But I think it's important that we still hold those standards, that we don't just implement something again because someone said it was really cool and it's really good, but we have to feel confident that if we're going to use something in that kind of setting, that we know why and we can back it up. So that's an important point. And the other thing that is a little bit challenging in this space is the regulatory landscape, or probably the lack of a regulatory landscape. So again, because we've got this really rapid acceleration, it doesn't really give regulation a chance to catch up. And in South Africa, there isn't really a regulatory body or regulation that sits in this space. So it does also just create a climate where people can sort of do things without necessarily thinking them through, or in a way that isn't necessarily how we would want it to be. So I think those are just important points that we've got to always ask ourselves, that we, whoever's going to be using it, if there's a clinician who's going to be using this piece of technology or this new software or whatever it is, that they themselves are comfortable to, it's still ultimately their name that's being put on that patient's file or that script or whatever it is, and they've got to kind of take responsibility for that. Something else that I have really experienced when talking about particularly AI in healthcare is the idea that it renders mainly in the kind of diagnostic space, or in suggesting management plans, or ultimately like doing the thinking on behalf of the clinician. That's sort of where everyone's mind goes, and that's what we all kind of imagine. But I think there's a lot of scope for the almost more sort of admin kind of tasks that it can do, or driving efficiencies in a consultation process, for example, which then opens up the clinician's time to be more engaged with the patient, or to do more of the clinical stuff, which I think there's an awful lot of value in that. So that view is something that I'd be really, really interested in unpacking more. And I think it's something that we kind of have to think of with technology in general, is that it should be there to do the more mundane, or the things that are less where there's less expertise required, and let the expert kind of do the things where the expertise is required. So I think from that respect, it should be something that we see more and more of. But again, the last, I guess, word of caution that I'd maybe give is that there is always the risk that a new technological intervention or a technological advance doesn't get used well by the user. So if I think of a simple example, is that we implemented an electronic health record or clinic system throughout our clinics a few years ago, and the initial uptake or use by our nurses was just really, really challenging, because it was this new thing they had to get used to, and it actually created a lot of friction. So again, there's still a human element to the use of technology, even if it's a technological thing. So the user still needs to be able to actually apply it correctly, or understand how to use it. And if it's creating more friction and more, kind of harm than it's worth, then we've also got to kind of weigh it up in that respect.
Yes, so at WIMI, we are also embarking on work in the space of AI scribes. I think every day there's a new AI scribe that is being launched somewhere, and I would say all of them are being launched, that I'm aware of, are being launched in the northern hemisphere and on the western side of the world. And in theory, that's not necessarily a problem, but I think how people speak, how they think, how they interact isn't the same across the world. And right now, the language models, including the AI scribes and the medical scribes, are being trained on largely American conversations. So I think it's important to realize that in very subtle ways, that thinking, that language, that logic is disseminating, and sort of we are absorbing it through the technology. And so I think being aware of it is important, but also having the ability to add our own voice to it. And I'm speaking as a non-South African, so it's weird for me to say this, but I think I've been here long enough. I don't sound like South African, but I've been here for 17 years, so I can see the difference between how a Belgian looks at life and how a South African, and again, there's many South Africans, but there are some noticeable differences. So in South Africa, for instance, people typically switch between at least two languages at multiple times in the same conversation, sometimes within the same sentence. That's not necessarily something that a large language model is used to. It thinks, are you going to speak English? Then you're going to speak English the whole time. Or you're going to speak Afrikaans, you're going to speak Afrikaans the whole time. But if you switch, then is it able to pick up those switch points? That's something that deserves a little bit of attention, for instance. Also, accents. In South Africa, we have a very diverse population. Everyone grows up in a slightly different community with different way of pronouncing things. So that's an opportunity to strengthen the language models and produce models that are able to accurately transcribe and translate South African day-to-day patient conversations, and not just the American ones.
I think you're touching on something so interesting there, because what you're describing is not actually a novel, really concept. Like we, you know, in Africa in particular, we've always kind of been, well, not always, but we've often been, you know, subject to research that's been done elsewhere in the world, or it's been, there's wider sets of publications that have been done elsewhere in the world, whether that's on a particular treatment modality or disease burden or whatever the case is. And sometimes there's this natural temptation to, you know, just take the results that have been collected elsewhere and apply that to our context. And there's obviously risks in doing that. I think what you're describing now is a slightly different manifestation of that. And I think AI and technology, and because it's all advancing so rapidly, is going to expose some of that a little bit more. But it's always been this, you know, this thing we've got to have our eyes wide open to say, in our context, what is the applicability and the relevance of all these different things that I'm looking at. I think what you're describing definitely is an opportunity, again, if we have the right hat on and have our eyes open.
Yeah. So I think I stand to be corrected, but in medicine, for a while, the way that we were thinking about psychiatry is largely driven by the German way. That's where the thought leadership was, and some of the nomenclature and the jargon is still has roots in German. The same is true, I think, for other parts of medicine where it's largely American way of thinking about it. But each continent has subtle differences in how we look at physical health, mental health, social health, how we try to bring healing, how we try to deal with suffering and pain. And what I hope is that this technology, so there's two ways, there's a pessimistic and a positive way of looking at it. Pessimistic would be, in my mind at least, we all going to converge to the same way of thinking, and it's all going to be driven by whoever is leading the technology. I think that's a real fear, a real possibility. The positive way would be, no, the technology will democratize how we do things, and so the Asian way or the African way, there's going to be a stronger voice of how that knowledge, that rich social element of medicine will come into play, because now that voice, that thinking will have a technological backbone. So there's going to be a scribe that is sort of tuned and optimized to support the African way of providing healthcare. That's also possible, but it's in our hands, I think, to make it happen. If we don't do it, no one else will for us.
Yeah, absolutely. And I mean, definitely, those both are like super valid possibilities, but it really is about us kind of taking ownership of how we want things to manifest in our own context. And I think the level of expertise and the ability to do, you know, sort of option B, it exists. I think we've just really got to kind of take the opportunity.
Great. I think we have not yet reached the hour, but we are 10 minutes away. Maybe now is a good time to pause for a second and allow for people to ask questions. So if anyone has a question, you're welcome to use the chat. Let's see if anyone has asked questions. No, I'm hoping that is actually allowed and possible. I think it's possible. So if anyone has questions, please use the chat for it, and then we will address your questions. If no one has questions, we can continue for a few more minutes. Maybe while we wait, do you have first-hand experience with in your communication with nurses and doctors on how so people facing patients every day, are they excited for the advent of AI? Are they sort of eager to test the functionality, and do they expect that it will make their life as a healthcare provider better? Or are they saying, oh, I can't wait to be retired because I actually am not ready for this new chapter?
I think it really depends actually on who you speak to, on that sort of individual, and not necessarily a particular group of providers, or because you definitely do have people who are very kind of wary of the change, and I think it's a natural thing. Most people just inherently don't like change. So I think there's that element of it which creates a lot of hesitation. But there definitely are some people who are so excited about it that they kind of try and use it everywhere, which is also great, again, provided we've got the right sort of structures in place to not be reckless. But there's quite a large variation. And what's also interesting is that if I had to almost guess, who would be the sort of archetype that's really excited about these advances and using them in their way of working, I would expect that it's sort of younger people, newly qualified, and actually it's not really what I see. It really, really depends on the individual, and it's, I guess, almost more their nature and their way of responding to change and newness that actually results in their view. So there's a big range, and a big range even within our organization, which is something also that's very interesting to navigate as we try and implement new things. We have to almost expect that some people are going to adopt it a lot more easily and they're going to benefit from it early on, and other people are going to need a little bit more guidance and a little bit more support, which is not wrong. It's just a function of how people are.
And I guess the same is true on the patient side. Some patients will be very eager for the consultation to be recorded, and others will say, no, you can't record what we are saying here.
I think on the patient side, at least in my experience, it's almost felt like that's sort of lagging a little bit further behind, and not in a bad way, but I think this healthcare interaction is such a sensitive one, that even with the introduction of telemedicine and the adoption is increasing steadily, and we're kind of seeing it pick up, but for a very long time, and still today, there's a sense of I want to see someone in person, or that's just what I'm used to, and you also kind of want to have that level of empathy and care. And so I think part of the question as well is, how do we not lose that in the virtual setting, because there's a lot of value and we can get out of that virtual setting, but we've got to make sure that we don't lose things that are still important to that interaction, because then we also lose value in other ways. So it's a lot to think about. In the patient space, even if I think of myself as a patient, it's a very different role to play in that environment versus being the provider. So I think it's felt to me, at least, that patients are taking a little bit longer to accept some of these sort of novel ideas in the healthcare space, which is probably not a bad thing either, that it just always keeps things in check and kind of again forces us to ask why we're doing this and is it the right thing.
Great, thank you. Let's read. I think there's at least one question. Okay, let's read. How do you strike a balance between applying academic approaches in this kind of work and pressures of the corporate space? What compromises do you have to factor in? And that is from Prince.
So I just want to make sure I'm understanding the question correctly, to strike a balance between applying academic approaches in this kind of work and pressure. So I assume what you're kind of getting at there, Prince, is this idea of the pressures in the corporate space being these sort of demands to move quickly and be agile and first to market, and there's always pressure to do that versus applying the academic way of thinking. So in that respect, I mean, it really is a balancing act, and you definitely have to accept that there's going to be modifications, if I can put it that way, to the way you would do it in an academic space when you are going to apply it in the real world context. And I think what I've really just tried to do, and I guess instill in the teams that I'm working with as well, is that we can't expect to do things in the perfect way, or in following the methodology that we kind of wish we could. But what is really important in that context is to be able to say, well, if I'm doing it this way, it creates these limitations, for example, and then those limitations need to be factored into the conclusions that you draw, the decisions that you make off the back of that information, so that at least there's awareness and an understanding of where those limitations come in and what they might be and to what extent could they impact the results. And then we're still, sort of being responsible in the way that we're doing research and using the results of it. So I think that's been an important thing. We can't, as a result of trying to be really rigorous in an academic sense, slow down the pace of working in the corporate space. But I think the way of thinking about what we have to just, kind of raise as a potential flag, this is a limitation I need to factor in. Does it make my level of confidence in this result more or less? And then, you still apply the results in the best way possible.
We've got a few questions. Shay asked a related question, which is, how can we encourage corporates to buy into more academic research to inform business cases and decisions?
Yeah, thanks for the question, Shay. And I guess this is the question that I'm sort of asking myself almost on a daily basis. And I think it is a bit of a journey to walk. It's a slightly different way of thinking and a slightly different way of applying like knowledge in a space like the corporate space. And I think a lot of it comes down to the way that you also kind of position the value that the academic methodology can bring. So obviously in the corporate space there's and rightly so, there's got to be a focus on value creation and how that is going to render for all the various stakeholders. And I think what I've tried to do in my space at least is to position the academic approach or that way of thinking as something that inherently does hold value. So if you can get to an answer that is more credible, an answer that is more scalable, or we understand that the significance of this result means more in a particular environment because we understand it well and we can kind of be confident about the result, we can justify the investment even further. We can feel more confident moving forward and focusing resources and attention over there because we understand the implications of it a bit better. So I think it's not, you got to try and move away from this idea of the academic approach almost being in contrast to this kind of value creation that we want to drive versus it inherently being something that can create value in and of itself.
Awesome. And the next one I will quickly answer. So Andrew asked if adherence to treatment in your PhD includes healthy lifestyle and nutritional adherence. I think the answer is no, because you looked at medical adherence.
Yes, correct.
So things that there is a script for, but I am sure that if somebody else did a PhD on healthy lifestyle and nutritional adherence, similar results would be found qualitatively.
I'd imagine so. I think part of the reason there's also that, we had the ability in a relatively objective way to measure this medication adherence through the dispensers. And even that has got limitations because we still can't be sure that the person is actually swallowing their pill when they're at home, but we're kind of making the assumption that they do. But in the healthy lifestyle and kind of nutritional space, it's a little bit more difficult to track on a broad scale. Like if you think of this 9 million cohort, we don't really have the ability to track physical activity and nutrition in an objective way in that sense. So it's part of the rationale, but I was obviously just very focused on the medication piece, and a lot of value would come out of doing it around the lifestyle factors too, but that's just one of the considerations.
I don't know if we have more time. There's more questions. Can we go over time?
More time, yeah.
Okay, so we'll just keep going. Thank you all. If you need to go, thanks for sticking it out all the way. But we're just going to keep going until we run out of steam. So the next question is, so thanks Danielle for your comment about that postgrad degrees are becoming more valuable more and more in demand in industry. That is definitely, I think, true. Both, and this is true for WIMI as it is for Dis-Chem, that we very much welcome people with masters and PhDs, and we create incentives and extra room for people to study while also working. So Ashley has a question. Do you think that adverse drug reactions and pharmacogenetics play a part in patients with medication non-adherence? And is this something that has been taken into account when unpacking the data as to why patients are non-compliant or have premature discontinuation of the medication course?
Yeah. So actually, I mean, absolutely. So just to I guess upfront make the point that my research topic is not diving into the reasons why people are non-adherent, more whether they are or not adherent and how that relates to mortality. But this point that you raise around, you know, unpacking the reasons why people don't stay on their medication is actually so interesting. I mean, some of the things, I mean, I've had some of my kind of preconceptions challenged through this process, and as I've worked with this data more and more, one of the things that I would have thought was a really big reason for people not staying on their medication, and probably one of the biggest, was affordability, for example. And in actual fact, you know, whether someone is on medical aid or if they're paying out of pocket for their medication, there was very little difference between the levels of adherence within those different groups. We also didn't really see a big kind of decline in adherence towards the end of the year when medical aid savings ran out, for example. So that was a preconceived idea that I had that was challenged. Side effects to medication, I would definitely say is one, and even just talking from my experience in clinical practice, the way that patients would describe the side effects that they had and that literally leading to them choosing to skip doses. Things like lack of understanding or education around a condition. Also some, I mean, the overall point is that it's really multifactorial, and we can't necessarily pinpoint a particular thing that is sort of the biggest factor, but there's a lot of different things to address. What is also interesting is that in developing countries, another thing that does tend to come up is kind of this, there's like, these belief models about taking treatment for a medication in certain cultures, which also creates additional complexity where people don't think that Western medicine is the route to take, or so ultimately it's a really complex topic. And I think what was also a little bit humbling, actually, if I'm honest, around the work that was being done around the adherence management function, was just how simple those interventions were and the actual impact that they had. So one of the only way that I could really rationalize that is to say that inconvenience or friction in the process around getting your medication, even in the private sector, is a very big factor too. So it's a great question, but really a lot of different things that go into that.
Great, thanks. Next is Jared, who's asking if AI is going to benefit specialists or generalists more. And his comment is that it seems that AI gives people with deep domain expertise superpowers, but that generalists are less likely to get good results, perhaps because they can't spot issues or prompt effectively. Jared, I think you are correct. So my understanding is that the AI that exists is still fairly narrow in task and scope. So the setup, the training has been very focused, and so it can be trained to get very good at answering a small set of questions. Is this cancer or is this not cancer? Is this TB or is it not TB? But if you just give a general X-ray and say what's wrong, then you would need an ensemble of multiple models that each ask specific questions and then jointly sort of compare answers and say, well, given all the answers from the AIs in the room, here's what could be wrong. So we're not there yet, where we have this multi-level AI stack where one AI agent gathers the information from 50 agents who then subsequently gather information from 500 agents. I think we'll get there, but for now, you're right that if you are looking at a specific domain, it's easier to build an AI that is really good at it. Okay, next one. I'm affiliated to a university and community organizations. How can we foster collaboration between your entity and community organizations that are undertaking behavioral science research? I'm in the community-based space in public health, and I would like to see if our entity can collaborate with your entity. I assume that's directed to you.
Sure, and I mean, thanks for the question. I think so definitely, I mean, ultimately, if there's things that can create value in our environment, we're always kind of open to exploring that. I would just obviously need to understand sort of what you mean by this sort of behavioral science approach and what that kind of would relate to. So, I mean, you can feel free to reach out. I think you should be able to see my email address on the invite or through the Teams call. So happy for you to reach out and to chat about that.
Great. Then we have Menaz, who says, I joined a few minutes late, but I'm curious to know if your PhD is data science in the engineering faculty or healthcare in the health sciences faculty, considering a similar pathway at the intersection of health and IT.
Yeah, I mean, so there's definitely no straight answer. I mean, mine is in healthcare, so it is in pharmacology, and that was really, if I'm being honest, a function of having studied in the healthcare space before. So some of the supervisors that are with me on my PhD project were with me on my master's, and that was in the sports medicine faculty. So they kind of joined because they were interested in the topic and they knew other people in the health space. So it sort of landed there, but really could just as easily have landed in a data science space. So I think I would really you kind of maybe explore both, or if you think you as an individual maybe have a natural inclination to one more than the other, those are all sorts of things that could influence your decision. But really, it's not that there's one right or wrong or one natural answer.
I can maybe add to that. So when I did my PhD, my PhD was in the Faculty of Health Sciences, but I had two supervisors. One was a statistician, one was a gynecologist. So even if you are forced to pick one box, you can still find ways to lean on and learn from experts from different fields. So ultimately, sure, it will influence your focus and the language that you choose when you write things, but you can learn very broadly across disciplines regardless of where you register. Okay, that question is, I think, Francesca, we've answered your question. Joshila, your thoughts on a science-led approach to pursuing social impact and creating value for the uninsured and underserved in SA. Any learnings from your experience?
Yeah, thanks, Josh, and thanks for joining. I think it's a great question. I mean, and there's a lot that you could unpack there. I think definitely the need for creating value for that portion of the population is huge. I think from my experience, I mean, some of the things that I would just mention that are important to take into account there is like the data set that you're looking at, right? And what I mean by that is that, like in the private sector, there's been, we've been a lot better at collecting data, and we've kind of, if I think back to what I described earlier about Dis-Chem, we've collected so much data over many, many years about various aspects of healthcare consumption and even retail behavior. But you don't necessarily have the same thing that exists in the public sector, which is where the population that you're talking about would primarily sit. So it becomes a little bit difficult to take the data from the private sector where we have more and it's been collected a bit better versus what sits in the public sector. And I think there's a lot of work happening there to try and improve on that and to try and change that and track patients better, etc. But it's very, very different. So again, it comes down to understanding what are the limitations, where are the gaps. Can we take information that we have in the private sector and kind of apply that in public? Is there other things that we need to look at? And just understand whether we that we're not looking at a complete picture, which I think is important. But other than that, I mean, definitely, I think the approach would be so valuable in that space, again, to make sure that if we're going to try and do anything to try and drive the sort of social impact or create value, that we can do so credibly, we can be confident in implementing something that we think is an improvement over what exists today, versus just trying something for the sake of it. So I hope that answers the question. It's quite but I mean, it's a great place to be thinking about, but a lot that we've got to take into account.
And then the last one is from Dr. Pitsi Kewana, and they're saying there's definitely a need for EBP. I assume that's evidence-based practice. In the corporate space, public-private partnership would really take things far.
Yeah, I mean, I think it's a great point, and I agree with both. Definitely a need for evidence-based practice in the corporate space, and I think that if we are able to drive this acceptance or this appreciation for the value that this evidence-based practice can bring, then I think it's something that we can definitely achieve. Public-private partnerships. I mean, this is really something, at least conceptually, that I'm so excited about. You know, in what I talked about earlier around this idea of influencing the change that we believe is inevitably going to come in the healthcare industry. I think that private-public partnerships are going to be very, very necessary, and things that we can really leverage to drive value, and then it's about kind of demonstrating that value and packaging it in the right way. But definitely agree with both of those points.
But maybe to add my last 2 cents is that so at WIMI we've been working with a wide range of different partner organizations and client organizations. Some were government or parastatal, such as the Medical Research Council, but we've also worked for universities, we've also worked for non-profits and for private organizations. So I think what I'm trying to say is that when you actively seek out collaboration and you prove value, you prove to be a trustworthy ally, then there are lots of opportunities to build partnerships, and then it doesn't really matter that much whether you are for-profit or non-profit or academic or government. If there's a shared purpose and a synergy and you're both working towards the same goal, then that's what matters, and not how you pay the bills at the end of the month. So with that, I want to thank you for this hour. Thank you so much. I trust that our audience has enjoyed it, and I can say we plan another one in 2 months from now, and we'll share the details of that in due time. Thank you.
Thank you. Thanks everyone for joining. Thank you so much.